Assalamu alaikum and good evening to you all. Welcome you all to our weekly tumor board session or fortnightly tumor board session. This program is organized by Oncology Club of Bangladesh, Oncology Club, and here today the chairpersons of this program is our president of Oncology Club, Professor M.A. Haisa. Sir, I want to introduce you. We have three foreign faculties today. One is Professor Dr. P.K. Shekran. Sir is former professor and head Department of Obs and Gynae Medical College, Calcutta. Vice President Foxy in 2010. Sir was also Secretary and Treasurer of International Society of the Study of GTD in 2013 to 2017. He is the chairperson of World Congress of Gestational Tuberculosis Disease and he delivered many memorial orations. And he is the visiting professor of the Peking University, Beijing in 2018 and served as a captain in Army Medical Corporation and active participation in 1971 in the Pakistan War. Sir, welcome you to the fortnightly tumor board session. Our another second speaker is Professor Dr. Joya Ghosh. Joya is she is our old friend. She is Professor Medical Oncology, Tata Memorial Hospital. And the third one is Professor Dr. A.K. Goodman. A.K. Goodman, she is the professor and the director of fellowship program in Gynae Oncology, Harvard Medical School, Boston. Today, the presenter of these sessions are the cases of the choriocarcinoma and also the carcinoma cervix. And presenter of today's presentations, they are the Dr. Amina Masood, another one is Dr. Nahid, and other two presenter, one is the Dr. Ruxana, she's from our hospital. At first, I request Dr. Amina Masood to present her case. And before that, I request sir, please, where is the unfortunately, the head of the Department of Rajshahi Medical College, Dr. Shaila Nazneen, she is busy in other program and she will join with us after some time, at 10 to 15 minutes. And instead of her, Professor Dr. Rokeya, she is with us for this program. And both of the doctors are from Rajshahi Medical College Hospital. He's calling, just a minute. जी आपा ढुकेन আপনি হ্যাঁ ওই আপনি ওদেরকে জিজ্ঞাসা করেন মেইল নাম্বার আছে আপনার মেইল করতে বলেন হ্যাঁ আপনার মেইল আইডি থাকলে ওদেরকে আপনাকে মেইল করতে পারেন আমি তো পাঠাইছি হ্যাঁ না আপনার তো মেইল আইডি আপনি দেন নাই আমি আপনাকে হোয়াটসঅ্যাপে পাঠাইছি সকালে I'm sorry, someone cannot join. So I request at first Dr. Amina Masood to present her case. Dr. Amina Masood. Samir.
Yes, ma'am. We have to share this one.
Yes.
Okay, I'm sharing the screen.
Yes.
Is it visible?
Yes, it's visible. Dr. Amina Masood, please. Present your case. Dr. Amina, please.
কানাপা উনি একটু ডিসকানেক্ট হয়ে গেছে, আবার রিকানেক্ট করছেন একটু।
আপনি তাসলিমা আপনি উইয়াপাটাকে লিংক পাঠান, উনি ঢুকতে পারতেছেন না। ওকে আপা,
আচ্ছা ঠিক আছে।
Honorable Chairperson, all my respected teachers, senior and junior colleagues, welcome to this webinar.
next Samir, yeah.
I am Dr. Amina, Assistant Professor of Sangan Rajshahar Medical College Hospital. I am going to present my case. A 17 years old housewife of a poor social class, married for 6 months, perennial, admitted into Rajshahar Medical College Hospital on 7th November 2019 with the complaint of amenorrhea for 14 weeks and excessive vaginal bleeding for last 12 days. Next. Patient state, she had amenorrhea for 6 weeks. Then she confirmed her pregnancy with home immune pregnancy test. As her pregnancy was uneventful, she did not consult with any gynecologist and did not undertake an ultrasonogram. But at her 14 weeks of pregnancy, she noticed slight vaginal bleeding, which was suddenly increased and deteriorated her general condition. An ultrasonogram was confirmed molar pregnancy, and she underwent suction and evacuation on 6th November 2019 at local clinic at Nauga district. But she had no document of beta ECG and histopathological report for uterine product. Next. After evacuation, her bleeding was continued and she referred to Rajshahar Medical College Hospital for better management. She gave no history of cough, dyspnea, chest pain, or hemoptysis. And with due consent, patient is examined and patient was moderately anemic and all other vital signs are normal. Next. On per-abdominal examination, abdomen soft, non-tender, it is just palpable and there is no organomegaly. On per-vaginal examination, per-vaginal bleeding present, vulva interested looks healthy. Next. Size, soft in consistency, and bilateral cystic adnexal mass is felt through the fornix. Next. Next. Investigation reports are here. On 8 November 2019, hemoglobin level was 7 gram per deciliter. All are normal. Extra chest shows no abnormalities detected before evacuation. But beta ECG reports were more than 1 lakh milli international unit per minute before evacuation. Next. On ultrasound report reveals that there is two separate cystic structure about 7.3 centimeter into 7.4 centimeter and another one 10 centimeter into 5.8 centimeter seen in the both adnexal region. Uterus suggestive of inflammatory mole. Size of the uterus about 10 centimeter into 4 centimeter into 6 centimeter. Next. Now she underwent repeat suction and evacuation on 8 November 2019 at Rajshahar Medical College Hospital. And histopathology report shows there is hereditary for mole. Patient was on stage 1. Before evacuation, patient was on stage 1 and scored as 6. And beta ECG report after evacuation on 10th November 2019, more than 1 lakh, 1,47,000. Then 4th cycle single chemotherapy agent methotrexate was started from 13th November 2019 and which will continue up to 14th January 2020. Next. And this is the report of all over report, the beta ECG report. Before evacuation, the beta ECG level was 1,27,000. After evacuation, it was increasing about 1,47,000. And after first cycle, it was 14,000. And after second cycle, it was 5,000. After third cycle, beta HCG was 4000, and after fourth cycle, it was 2000. Next. Thereafter, patient did not come as per follow-up schedule into the Rajshahi Medical College Hospital. She again admitted on 10th October 2020 with the complaints of pervaginal bleeding after about 1 year. And we advised MRI. The MRI findings are MRI film is not available, but reports here are suggestive of choriocarcinoma with parametrial invasion with bilateral thecal lutein cyst. Next. X-ray chest showing bilateral lungs metastasis. Next. Then patient was referred to oncology unit at Rajshahi Medical College Hospital. Here patient was stage 2 and rescored as 11. Again, single agent chemotherapy with methotrexate was started on 18th October 2020. Then she developed crisis and respiratory distress after one cycle of chemotherapy. And I am very sorry to say that she died on 31st October 2020. This is all of my case.
Hello, Dr. Amina, Dr. Jaya here. Can I ask a question? Hello.
Yes.
Am I audible?
Yes, ma'am. Audible.
Okay, I think there is some echo in the system. So maybe I'll just type my question till I see the echo question.
Sound system is disturbing. Madam, please again.
Amina, are you having two devices in your room?
Sound system.
আপনি কি দুইটা থেকে লগইন করেছেন নাকি একটা বন্ধ করেন সেজন্য ইকো হচ্ছে আপনার যে কোনো একটা ডিভাইস স্পিকারটা বন্ধ করেন
আমিনা আপনি দুইটা জায়গা থেকে লগইন করলে একটা বন্ধ করেন আমিনা
Yes, madam. একটা জায়গা থেকে লগইন করে শুধু
একটা থেকে ঢুকছেন
আমার সেট
now it's okay. So Jaya, you can ask that question now.
Okay, so I wanted to ask, like, this patient had hydatidiform mole with a beta HCG of about 1 lakh, which was about 1,47,000 at the end of evacuation. So the decision to follow up this patient to see whether this beta HCG came down and then to decide between whether it's a gestational trophoblastic disease versus neoplasia. Because all these hydatidiform moles, about half of them, may not continue or become a neoplasia. So that is what I wanted to ask, whether it was a concern regarding follow-up, why we started her on chemotherapy versus considering her for observation alone. I mean, for observation meaning regular routine beta HCG monitoring, and then to see if there was a log reduction in beta HCG or not.
Thank you, madam. Very much. Thank you. Here we display the beta HCG report. After fourth cycle, beta HCG was 2000. The decreasing level was not satisfactory. I think it is better to continue the chemotherapy.
No. My question is, after if you show us the table of October, her beta HCG was like before evacuation, it was close to 1.4 lakhs. But immediately after that, we started chemotherapy. We did not wait for and follow them up with weekly beta HCG to see if there is a log reduction. That is what I'm trying to ask. So after evacuation. So what I'm trying to say, this patient had a hydatidiform mole. Now, hydatidiform mole with a beta HCG of 1 lakh. So there are two things. One is that we follow this patient up, see if there is a log reduction in beta HCG, and then decide whether this hydatidiform mole, which is a gestational trophoblastic disease, has gone on to become a gestational trophoblastic neoplasia, meaning if there is a plateauing or a rise of beta HCG. the other indication for chemotherapy would have been that if we are concerned about, because this is like a high risk molar pregnancy, if there is a concern regarding follow-up, whether to give a prophylactic chemo, of course, that is debatable. So did you start her on chemotherapy thinking that this is prophylactic? Because in that case also, generally a single course is given, because here we haven't observed this patient or followed her up with weekly beta HCG to check for a log reduction in beta HCG even without chemotherapy, because she may not have needed chemotherapy in about 50% of the time.
Madam
Jaya,
Saha,
I have a question.
Madam Saha, can I get some clarification about this case?
Yes, sir.
Okay, the first evacuation was done, and then the second evacuation was done because of incomplete evacuation, I suppose.
Yes.
How many weeks or days after that?
Dr. Amina, how many days the second evacuation was done? Amina?
Sorry, madam. How many?
ইভাকুয়েশন কতদিন পরে করা হয়েছে? প্রথম ইভাকুয়েশনের প্রথম তো তার ওই মফস্বলে কোথায় ইভাকুয়েশন হয়েছিল, পরে আপনাদের হসপিটালে ভর্তি হওয়ার পরে আপনারা ইভাকুয়েশন করছেন, ওটা কতদিন পরে করেছেন?
After 48 hours.
After
48 hours.
48 hours.
48 hours.
After
48 hours, sir.
48 hours.
48 hours because of the bleeding.
Yes. Yes, sir. Because of bleeding.
Because of the bleeding.
Yes, sir,
That means
because of
it was incomplete.
Yes, sir.
Incomplete evacuation. So second time after evacuation, did you check with ultrasound whether it is complete or not? The evacuation is complete or not? Could you check with the ultrasound?
After second time of evacuation, active PV, there is no severe active PV bleeding, mild PV bleeding, but we perform the beta HCG after 48 hours, not the ultrasound.
Now, Professor Jaya was asking a very important question. What was the indication for chemotherapy in this case? After the complete evacuation, then you wait and see the HCG pattern. That is the way we are to follow. So in this case, after the second evacuation, because it was incomplete evacuation during the first time, because of the size of the uterus might have been bigger, and it was a suction evacuation. She was admitted with the bleed.
Yes, sir. Yes, sir.
Suction evacuation.
And probably there was not have any difficulty for dilating the cervix. In fact, in molar pregnancy, it is not difficult at all. So the first evacuation, probably it was incomplete evacuation. Because of the incomplete evacuation, she had severe bleeding. And then we have to do evacuation second time after 48 hours. Now, my question was, at this juncture, probably we could check with the ultrasound after 1 week or 48 hours after the second evacuation to see whether there is incomplete or is it complete or not. That is the first point. Once it is complete, then if the beta HCG is rising or plateauing is the question to start chemotherapy in any case of molar evacuation. After molar evacuation, we don't usually go in for prophylactic chemotherapy unless you get a patient who is not at all going to come for follow-up. There is a place for prophylactic chemotherapy. Otherwise, you make a diagnosis. That was what Professor Jaya Ghosh was asking. Is it because of the bleeding you started the chemotherapy, or with the high level, which would have come down if once you evacuate?
Sir, let me help. Probably after the 7 evacuation, they have done a beta HCG and they have seen that it was rising. 120,000, it came to 147,000. Okay. So the trend of rise was there. That prompted them to start the single agent methotrexate because they scored it is low score. So as there was even they have done the second evacuation and even they have not done the ultrasonogram, I understand, but there was no bleeding. So it was assuming there was a complete evacuation. But unfortunately, the second reading of the beta HCG was more than the before the second evacuation. So it was 120,000 to 140,000. So probably that figure prompted them to start the chemotherapy.
You may be right in starting, but as per the definition of diagnosis with GTN, we have to wait. Once the evacuation is complete and you have to see the HCG pattern, one value may not be making a diagnosis of GTN. So after complete evacuation, you have to follow with the regular HCG and one value rising is not sufficient to say that it is GTN. Probably it is still incomplete or complete. We are not very sure. And if it is complete, one value is not sufficient to start chemotherapy. We have to wait for 3 increase in the value. 3 values consecutively showing increase is an indication to start chemotherapy, or the plateauing level, that is fall of HCG is less than 10% of the previous value, is an indication to start chemotherapy. In this case, because of the high value immediately after evacuation was prompting us to start chemotherapy, and also afraid of the patient may not be coming for a proper follow-up. So in this case, the most important thing is the follow-up after evacuation. That's the most important care that we have to give. So this patient, just one value going up by international definition is not a GTN. At this tumor value, we have to wait. If the patient is not having any bleeding, immediately there was no indication to start chemotherapy in the first place. Having started, then we have to see that she going for complete remission. So how many courses she was given? It is a methotrexate folic acid regime that you have started, isn't it? Madam,
So
it was
methotrexate, they have given 4 cycles, 4 pulse they have given.
That is methotrexate along with the folic acid alternative dose, that 8-day
No,
course.
I think it is only single agent methotrexate they have given.
A single regime, single agent, but is it methotrexate folic acid regime or methotrexate alone? What are the dose given? Madam Amina, how much was the dose of methotrexate given in this patient?
Methotrexate and folic acid.
Methotrexate and folic acid. Milligram per kilogram body weight on days, so 1357, and folic acid the alternative days. Okay, 8-day course. After checking the complete blood count and LFT, RFT, you have given 1 course. So how many courses could be given like that? 4 courses. 4 courses, isn't it?
4 courses.
4 courses. And the beta HCG was coming down very nicely. Yeah. So our is wait for at least give 2 more courses once the beta HCG has become negative. So she was having a very nice fall in the beta HCG. She was responding to the methotrexate folic acid regime. It has come down to, I think, in 100 from 1 lakh and above. It has come down to hundreds, and we could have continued to give it till it becomes negative. And after it has become negative in such a high value initially, probably at least 1 more course has to be given to see that if she is in remission, if she goes in for remission. And then we have to follow with HCG. Unfortunately, this patient was lost to follow. That was probably another situation where we are not in a position to help. So she didn't become negative. Is that Dr. Amina? She didn't become negative for beta HCG.
Maybe.
It was never normal.
It was normal. So after normal,
still it was not normal. It was low, but it was not to the normal level. It was around 100. Yeah.
So she needs further treatment. At that level, we have to give further treatment to see that it will become negative. She is responding well. So continue to give the same dose, same drug, because she is responding very well, and give it till it becomes negative. And even if she has become negative, see, even if the HCG has become negative in GTD or GTN, there will be still live cells in the body. That is why we want to give further, so that there is no remission. So you give at least 1 course. Now the standard treatment is 2 course minimum after it has become negative in a low risk case. So after this patient was obviously not staged initially, it was stage 1 only, and score was 6. I don't know what was the point for score 6. Can you help us, Dr. Amina? Why you said it? I think stage 2 and 6. To classify the stage 2.
Her beta HCG at first, when I record, more than 1 lakh.
Pardon me?
Beta HCG report more than 1 lakh.
That isn't put her into 0.6 response.
It carries 4 plus.
Huh? Pardon?
Her beta HCG report more than 1 lakh, it carries 4.
Ah.
And size of the uterus was 10 centimeter into 4 centimeter into 6 centimeter.
Okay,
It
there
carries 2. 4
up.
plus 2, 6.
That is a lutein cyst only.
Yes.
That is not
Size of the
considered.
uterus with bilateral thecal lutein cyst.
Thecal lutein cyst is not considered as a tumor mass.
But size of the uterus.
Sir, actually, the diameter of the tumor mass was 10 into 5 centimeter.
That is not considered as a tumor. It is because of the high SCG level, the ovary has become cystic, lutein cyst. That is a mass. It is not a secondary on the tumor of the on the ovary. It is because of the high level of SCG, it has become multiple cystic change. It is not equal to a secondary in the ovary. I hope, Madam Shahana, what's your opinion? Dr. Jaya, you have to unmute, madam. Unmute, madam.
Yeah.
Shahana, unmute karo.
Taslima,
So,
why it is 6? Explain, Taslima, why it is the score is 6?
Acha, at first, the before evacuation, the beta HCG level was more than 1 lakh, and that it points go to 4, and the
No.
diameter of the uterine mass is 4 into 10 into 4 centimeter, more than 5.
You have to have a nodule in the uterus to be considered as a nodule. The size of the uterus is not measured.
The not tumor size. So not tumor size. The size into the uterine cavity diameter. The diameter of the intrauterine mass is
There was
more
a
than
mass.
5 centimeter. More than 5 centimeter. That is called 2.
Okay. What's a mass or is it a,
Mass. So there is mass in the uterine
that
cavity.
is before the second evacuation or after the second evacuation? After the second evacuation.
Before the second evacuation.
Before the second
evacuation.
Before, so after that was evacuated in the second time, isn't it? So how to it didn't form a mass there. There was incomplete evacuation in the first place, and the second evacuation was necessary because of the heavy bleeding. And after that, we didn't do a scan. We didn't do a scan to see whether there is any nodule on the uterine wall or not. So it doesn't score like that. So the lutein cyst on the ovary is not considered as a secondary on the ovary to count it as a mass.
yeah,
Dr.
I
Jaya,
had
please.
also wanted to say that, this pre-evacuation beta HCG is not the beta HCG that we take for scoring in a GTN. It is the beta HCG at the time you start. Of course, in this patient, she has not had, an observation period.
Yes.
But like if we had followed her up with weekly beta HCG and suppose her beta HCG had come down to 2000 and then it had plateaued at 2000, then 2000 would have been the beta HCG that you would have taken for scoring.
Yeah.
Because pre-evacuation, many patients will have a high beta HCG. So that's why the importance of following the patients after a hydatidiform mole with weekly beta HCG, because if sometimes, if you repeat it after 48 to 72 hours, we may not get a exact value. So if our bleeding has stopped, we repeat an ultrasound as Professor Sekran had said, and then we repeat a beta HCG after a week, then that will give us a better idea. That's what.
Yes, perfect. So that is how we have to go. Pre-evacuation is not actually the basal value. Actually, after evacuation, you have to take beta HCG, but you can take pre-evacuation also. From there, you have to see the fall or rise, whatever it is. So after evacuation, the beta HCG after 48 hours may be the better value, or at least 24 hours after evacuation may be the basal value, from where you can go for rise in HCG or flat. Here, we didn't have time given to for the patient to go in for remission spontaneously. She would have gone for GTN. As we have seen that with treatment methotrexate also, it has taken some time for the beta HCG to come down. Unfortunately, we didn't see that the beta HCG has gone for negative. It has to become normal. And then at least one more course. That is I am stressing on that point. Even in a low risk case, beta HCG after having normalized at least 1 point. Nowadays, it is 2 courses, and even people are telling that 3 more courses after it has become negative, so that there is no remission. I mean, there is complete remission, no recurrence of the tumor. So that is the standard now. So here, because of the bleeding and because the beta HCG after evacuation was also raising, the chemotherapy was started. Maybe because of the patient may not come for a proper follow-up. That may be also the reason that they have started. But having started, we should have seen that she going for complete remission by continuing with the single agent, which she was responding very well from more than 1.5 lakhs or 1.5 lakhs to 200 or so. She has come and we should have seen that it becomes negative, and then 1 or 2 or even 3 more courses are to be given for complete remission of the condition, and then she has to be followed. Unfortunately, this is what we see in India also, that patient may not come for a proper follow-up, and that is
I-
the problem.
Yeah, so I just wanted to add,
Okay.
like, we face the same difficulties regarding follow-up. And the only thing where we have saying that what has helped us is, the many of our medical social workers, they have, and the NGOs, they have made a lot of difference in ensuring follow-up of these patients, because we just tell them and ask them to follow up, and many of them, as you mentioned, are from such poor socioeconomic status that there are so many socio-economic issues that, unless we are able to at least help out to some extent in those issues, they don't, they're not willing to come for follow-up. Some of these patients, like in TMH, Mumbai, they come from far off places. So they help out with basic socio-economic issues and follow-up.
Yeah. And the counseling of the patient, we need not frighten the patient at the same time that we have to tell them that, see, this is a chance of something like a cancer, which has got 100% cure, and you can have pregnancy and children. So they have to be counseled. That is what we have to see. In our situation also, people are poor. They are not able to have the very regular follow-up as the Westerners are doing, but still we will be able to counsel them properly so that we get a very good follow-up. So that's all. You are having a cancer, or you are having the risk of a cancer, which could be 100% curable cancer, and with the preservation of fertility, so that they are convinced that you can get a cure. So I hope the patient, if they are not coming, what are we to do? So in this case, we could have insisted somehow to see that the beta HCG is normal, and then 1 or 2 more courses should be given in a low risk case. Here, the scoring system is not before the evacuation. After the evacuation, the HCG you have to take. Then you have to see whether it is rising or plateauing. That is how you make the diagnosis of GTN. Very simple. So in this case, with one value, we are afraid and we started giving. And having started, we should have seen that we say the complete remission has occurred. Now the patient was lost to follow-up. Again, it's a problem in our side also because of socio-economic problem in many of these girls. And the she's a teenage girl, unfortunately. And teenage girls are at a higher risk of developing this GTD. Second problem was she came with the secondaries from the lungs and whatnot. After how many months, madam? After how many months she reported after the chemotherapy?
Amina, it's after 1 year?
After what year?
After 1 year.
1
But
year.
during this 1 year, she should have been some sort of a follow-up. At least urine pregnancy should done. But she has now gone for a negative thing. Having come the second thing, with the secondaries in the lungs, which is stage 3, and the beta HCG also high with a very, here you have to count that each metastasis in the lungs that we have shown, multiple, that has been scored as number of metastasis there. And then here the score is 11, and unfortunately the treatment given was single agent again. When the score is 11, it's a very high risk case. It started with the multi-agent chemotherapy at that time, and that gives a cure of nearly 98-100% again, in spite of all these things. So the second time, when the patient has come with a higher score, higher risk case, again, single agent, there is no place. Unfortunately, we have to start with the multi-agent chemotherapy after giving blood and blood products and correcting our anemia. And carefully, we have to give the multi-agent therapy, which will get a cure, even if there is a metastasis. So metastasis is a stage 3. If the score is below 6 and below, still you can start single agent. But here the score was 11. So again, it is a failed previous chemotherapy. That is another point which you have to think. Chemotherapy, if you see the chart, that is a column which is failed prior chemotherapy, single agent, 1 point, multi-agent failure, 2 points. So that also increases the risk of the patient. So accordingly, we have to properly score the patient. The scoring, if not done and correctly not picking up the correct chemotherapy, will make a failure. Unfortunately, we lost the patient because of various reasons. And the patient's inability to report on time was the major thing in this situation. So I will come second time, stage the disease, rescoring was done. Any score which is above 6, is requires multi-agent chemotherapy. So whether it is stage 2, stage 3, multi-agent has to be given.
Yes,
Dr.
sir.
Leah,
And
please.
one more thing I wanted to say was that because this patient has such large cannonball mets, and because there is a high risk of bleeding even with a multi-agent chemotherapy, we generally nowadays start for these kind of patients with a pre-phase EP. So that is just platinum
Induction
and
therapy, what do you class induction therapy? Induction
uh,
chemotherapy.
yes, induction chemotherapy, where we give cisplatinum and etoposide for 2 days. And sometimes actually we are not, even not able to give it for 2 days because patients come with an albumin of 2, very poor performance status. In such patients, we might even give it for just a day or just a flat dose of 20 or 100, see, tide over that initial period and then give her the next dose so that she does not bleed. So I think they bleed if they don't respond, like in this probably like we were giving single agent methotrexate, as well as they bleed if they have a good response because they're very chemosensitive. So I think in this patient would have probably started her with an induction chemotherapy.
No, but
That
usually
treatment
that is recommended beyond 13 and above, usually score. But in this
yes.
case, that may be better. That may be better to see the dose delay. How many courses could be given second time? Dr. Amina? Dr. Amina, how many cases?
Sound problem, sorry, sir. Sound problem.
Second time?
And how many
Sir,
chemotherapy
sir,
given?
it is Dr. Kamal, a oncologist. I would like to have one main thing clear to all our participants that Jaya and you are trying to emphasize on the first situation that even the very high score of beta HCG in this type of patient should not prompt us even for a single agent chemotherapy. And one score after evacuation is not enough. I think that is a very strong point, Shahana, that should be
Yes.
very clear to everybody.
Yes.
That if there is a situation like that, even we do an evacuation and we need to very confirm that SAR was making very clearly that whether we have done at least the ultrasonogram to make confirm that the evacuation is complete, because we keep something behind. So there is a obvious reason that it will not come down. And once there is a good evacuation, then we need to weekly monitor the beta HCG for at least 3 weeks to decide that whether we should start chemotherapy or not, because these things need to be very clear. Otherwise, this 140,000 this score is always prompting us to start single agent chemotherapy. And sometimes we, as Jaya was telling, that 50% of the patient will not need chemotherapy. They have become they take the treatment of this chemo, number one. And sir, another thing that you mentioned, I want to repeat the thing to my colleagues, that when there is a metastasis and it is a failure of the first chemotherapy, there we should be very aggressive. We should not take a risk of single agent here, because we may lose the chance of a cure patient by treating a patient with single agent chemotherapy. So this was the 2 points I wanted to re-emphasize, because probably in the long discussion, our colleagues may not have taken the message properly, that you were repeatedly telling that starting chemo was not justified. Probably in that case, Jaya was telling and you were telling, and we need to wait. The main message is we need to wait with weekly monitoring on the beta HCG for 3 weeks, unless there is a serious situation. I mean, as you are telling, that the loss of follow-up and other special situation. So I think these are the message that we should be carrying. Otherwise, in any center, sitting in periphery or center, maybe this type of 150,000 beta HCG or slight bleeding may prompt us. And another thing, sir, you have repeatedly mentioned, that is another very important thing, that after touching the normal line, at least 2 cycles of chemotherapy, whether it is single agent or multi agent, whatever we are giving, that is a big problem even in our oncology colleagues. Sometimes we are not following it. So probably my concern is that we are losing the opportunity of treating some curable patient and making them resistant. So thank you, sir.
That is the take-home message.
Kamal bhai, I want to supplement.
So just a minute, Jannatul. So the take-home message from here is that even after it is 1,40,000 or 50,000, even after evacuation, immediately just after that, we shouldn't start the chemotherapy. We must follow up the patient, and we must have to do ultrasound to see whether there is residual disease, and weekly beta HCG. If it is plateauing or if it is rising, then we may start chemotherapy. Another thing is that the ultrasound, that if the second time when the patient comes of the refractory disease or the recurrence, in that case, every time every patient should be re-staging and re-scoring. Am I true, sir?
Yeah.
And
We
sir,
should
just
say that-
one. Sorry.
Yes, ma'am.
No, sir, please go ahead.
Can I supplement?
See that the uterus is
Kamal
empty.
bhai?
That is the most important. After the first evacuation, probably it was not complete, and she started bleeding. That requires the next evacuation. After the next evacuation, we should see the uterus is empty or not. We should see that any molar tissue remaining there will have high HCG coming up, and we will be unnecessarily worrying. So you have to make sure the uterus is empty. After the first evacuation, you call, if there is nothing, take the HCG after 24 hours. That may be one, maybe the basal one. Consider not the pre-evacuation. Pre-evacuation, if at all taken, that is okay. But after evacuation, she should report after 1 week. Do a scan to see that the uterus is empty. Do a beta HCG after 1 week, so that you are going to get that the levels coming up or plateauing or coming down. As Dr. Jaya was repeatedly saying, it normally it should fall by 1 log. That means from 10,000 it will become 1,000 to 100 to 1 or 10, like that. That is a good fall, and within 8 weeks, majority of the cases become negative. So if make sure that the uterus is empty, that's the most important. If it is incomplete, then the beta HCG will go up, and we will be unnecessarily giving chemotherapy. Now, having started the chemotherapy, then once she was responding, then we have to see that it is continued. And once the second time after the scoring, that was to be carefully, scoring was to be done, and accordingly you stage the disease and score more than 6, it becomes high risk, and high risk cases require multi-agent chemotherapy. Even the score of 5 and 6 may not respond to single agent, but 50% at least will respond. Rest of the cases will respond to subsequent treatment. So that's why it is still kept. We haven't included the 5 and 6 in the separate group. There was a big discussion in the last meeting that whether to separate it or not. The 5 and 6 group who may not respond very well to single agent. But our consensus was that once this patient will respond at least 50 to 60%, and rest of the cases can have complete cure with the next single agent depending upon the level of HCG or multi-agent therapy, so that you don't risk all the case of 5 and 6 with a multi-agent, the toxicity of multi-agent. That was a consensus. There was a big debate amongst us before settling that FIGO guideline 2018. So this was considered like that, and that is why. Now, in the general way, nowadays, so there are certain conflicting or some difference of opinion with the green top guideline and the FIGO 2018 guideline. The people who was there, the same people who are sitting with the FIGO guideline have made the green top also. Green term, what is the difference is they don't agree with the starting of oxytocin at the time of evacuation, until unless there is heavy bleeding. But in the FIGO, we say that you started because many of these cases will require oxytocin at the time of evacuation. Our aim is to control the bleeding and avoid a perforation of a soft, big uterus. In this case, the uterus was big, palpable per abdomen. The bleeding will be profuse, and during suction, immediately she will start bleeding. So it is better to start the oxytocin from the very beginning, though other guidelines may go. In our countries, we have to see that initial bleeding is one of the dangerous things. We may not have sufficient blood, so avoid bleeding. So start the oxytocin, that is my request. And then regarding the post-molar follow-up, if the beta HCG has normalized within 8 weeks, she requires the total follow-up from the evacuation only 6 months. Don't keep the patient for unnecessarily worrying them. You are in the chance of developing cancer. I know she can be let off from the follow-up. And if it is a partial mole, once it has become negative, just one more value after 1 month. If it is negative, she is let off from the follow-up. Don't make the patient unnecessarily worried about these things. She can be let off. So also after chemotherapy, we don't allow them to become pregnant within 1 year. So maybe it's a safeguard. We don't have a solid proof that it will produce congenital anomalies of the baby and other things. We hope that within this 1 month of 12 cycles or 8 to 10 cycles, the cells which were active at the time of chemotherapy will be going over 200, 300 follicles in every cycle, so that you, after 1 year, you may have a chance of having normal pregnancy. Having said that, we have seen that in our series, there was no congenital anomalies of about 180 cases after chemotherapy we have followed up. There was no congenital anomaly. It is the same as the normal population. In fact, we had some cases, only few cases required multi-agent chemotherapy because our patients were picked up at the early possible time. Though they were all poor, they were coming for a regular follow-up, which has helped us. So counsel the patient very carefully, at the same time telling that you are likely to have a cancer, which can be picked up, which can be cured, and you can have fertility, future fertility. This is the guarantee that we have to tell. At the same time, little bit of warning that it is a situation up to 15% can have a minimum chemotherapy may be required. So who is this 15%? We cannot see in the beginning. So they have to be picked up only by proper follow-up. The high risk patients are there, like elderly people, patients with more than 4 weeks from the gestational age, size, bilateral thecal lutein cyst, a beta HCG pre-evacuation more than 1 lakh are considered as high risk. So only these patients may be benefited by a prophylactic chemotherapy. In a low risk case, there is no place or benefit for prophylactic chemotherapy. If any patient of this group is not going to come for a regular follow-up, there is still a place for prophylactic chemotherapy, even though we don't advocate it. But we have to see our situation, our position of our people. A high-risk mole is not going to come for a regular follow-up, may be given a prophylactic chemotherapy at the risk of still that patient developing malignancy, and this particular drug may be ineffective or she may require more courses. That is why we don't recommend prophylactic chemotherapy. So it is a very important case. At the same time, it is a sad ending. That was very sad. A young patient, potentially salvageable patient, but salvageable case, they have to come for a clear instruction with that. They have to come for regular follow-up. That is our problem in our country also. This happened. They will not come for a proper follow-up because of the social and economic problems. Hopefully, we will all improve. And I am having a special thing about Bangladesh because I walked from Tripura to Dhaka during 1971 when I was just 26 years old as a captain, as a doctor in the infantry battalion. So whenever I see Bangladesh or Bangladesh people, I am very much having a very high sentiments about our people. So that's all special reason for me that we should all try to see that our people, our girls are safe. Shahana madam, is anything else? Dr. Jay is
Sir,
available.
sir, it is Kamal, sir, again. I want to thank you on behalf of Oncology Club as also a national of Bangladesh, because at the age of 26, what you have done, I wish I was there to work with you from Tripura to Dhaka. Thank you very much for your personal contribution at the very need of my country. From Bangladeshi citizen, my all our gratitude to you, sir. And whatever you said, I think Jaya and you, it was educational for us, because the problem is it is a gray zone. Sometimes who to treat, how to treat. Unfortunately, in our country like India, we are not fortunate like Joya that's working in a center where they have multidisciplinary approach. So me as oncologist sitting in one corner, my another gynecology colleague sitting another corner. So when somebody is getting a patient, maybe we are not discussing with each other. So this is another limitation we are having. At definitely poverty is another issue. So before, sir, there was another professor of gynecology, very young, promising professor, Professor Jannatul. She was trying to supplement something. I would request her to supplement her comments so that then we can come back to the discussion. Jannatul.
Dr. Kamal, he is the scientific secretary of this oncology club. The oncology club is organizing this program weekly, the fortnightly tumor board, and the alternate week there is the journal club and also the debate session. Dr. F.M. Kamaluddin, he is the scientific secretary of our this oncology club. Dr.
Jannatul, please.
Jannatul, please.
Okay, thank you. Thank you. I am working at BSMMU, and actually, I think in this case, if I shortly say that in this case, first time over treatment was done, and regular and follow-up was done following the FIGO guideline. We know that the diagnosis of postmolar GTN is based on the FIGO guideline. There are three criteria. A plateau in the beta HCG level over at least 3 weeks, or a rise 10% or more rise in beta HCG level for 3 or more values over at least 2 weeks, or persistence of beta HCG level 6 months after molar evacuation. So in this case, without following up of this patient, prematurely chemo was started, and I don't know why scoring was done at that time. Scoring should be done when this is a diagnosis will be done that this is a case of GTN. Then we will do scoring. Premature scoring was done in this patient, and prematurely methotrexate was started. And second thing, what I want to say that after second evacuation, this time under treatment was given. Patient was under treated because there is already lung metastasis. This is stage 3. And of course, this time scoring should be done as this is a case of GTN now. And this is for stage 3, and brain metastasis should be excluded in this patient, as there are multiple shadows in the lung. So every possibility of brain metastasis in this patient. And this is an ultra high risk case. So this time combined chemotherapy should be given. Thank you.
Thank you, Dr. Jannatul.
স্যারকে একটু বলেন আমাদের কি স্কোরিংটা একটু ক্লিয়ার করে বলে দিবে।
No, before that, I have one question to Dr. Shekran. Professor Shekran,
Just
you wanted that, Tasnima, 1 minute. Professor Shekran, you were very much keen about the total clearance evacuation of the mole. I understand that. But if there is a situation that the total suction evacuation was not possible due to the excessive bleeding, say in a situation where the gynae colleagues are not able to do due to the severe bleeding, so if there is a situation like that, what will be the recommendation? And then they want you to please explain the scoring system first time and second time. They want you to make a bit clear on the scoring system.
For a student.
Okay. Scoring system, you have to keep the table with you. Even if you can't remember it, you have the scoring system somewhere with you, and that is going to help you. That has to be according to that. Each point has to be given that point accordingly. you have to score it. You know, this is the score is to be scored like this. The score is on eight factors: age, antecedent pregnancy, that is when you are making a GTN diagnosis. Interval means from that pregnancy to this time. Then level of SCG. Okay.
The interval, the interval, sir, in case of interval, from where we start to count?
Interval of the last pregnancy and the present GTN diagnosis. Suppose I had an evacuation of a mole in a particular case 6 months back, and then now I am making a diagnosis GTN by the SCG follow-up. That is 6 months. So interval in months, less than 4 months, 0. Then 4 to 6 is 1 point, like that it goes. So that is from the last pregnancy from where. If the patient has come a non-molar GTN or choriocarcinoma after a normal delivery, from that to the time of diagnosis is the interval of the antecedent pregnancy. So there's no confusion there. Then again, the tumor size, number of site of the tumor, and the failed chemotherapy also is considered as a point. When the lung shadows are seen on chest X-ray, you should go in for a brain MRI. If the lung shadow is not there, you need not go further. You can stage it accordingly. Chest X-ray is good enough. But if you are having a doubt about the mass in the lungs, then you may go in for a CT scan of the lungs also, chest also. So if any shadow seen on the chest, then go in for the brain. Liver and uterine, other things, you can go for the ultrasound or CT scan. So accordingly, score is done. So according to the score only, you have to start the chemotherapy. So, and the ultra high risk is now considered, but what was being told by Professor Jaya, that those patients may not stand the initial multi-agent chemotherapy. So you go by a slow dose of 2 drugs only, not the everything together, so that 1 or 2 cycles are given every week and then start the full course. The response to these patients are better. So scoring has to win. I didn't get Sir Kamaluddin's question initially. It was some disturbance for me. Can you repeat the question, sir? Other part of
Sir, my question was that we know that we aim to make a complete evacuation, but for some situation, maybe some bleeding or some situation, our gynecology colleague failed to make a complete evacuation because of a severe bleeding. So what is the suggestion? I mean, shall we start chemo or we go for hysterectomy? I mean, what is the solution?
You have to empty the uterus of the mole. That is the first requirement of a management of a mole. And that's why preferably under ultrasound guidance, if you can. Never mind, but you do a scan after at least after 1 week to see that is empty. If it is empty, do the second curettage. A second curettage is not for histopathological diagnosis of choriocarcinoma or anything. It is not done routinely in every patient. Only in a patient who's having some thing left inside the uterus, especially after involution of 1 week time, then that patient requires second evacuation. Now, suction evacuation is a very, very elegant way of emptying the uterus of the moles. Especially if it is complete mole, it just comes onto the suction bottle within minutes. It is not unlike the initial period in our service. We were using the sponge only motion, home forceps, and making minutes, hours together with a lot of bleeding. Now it is suction evacuation, very simple. It will come onto the bottle. And at the end of the evacuation, please do a gentle curettage at the same sitting. Patient is under anesthesia. So do a gentle curettage without perforating the uterus. You should know when you are curating what you are doing. In a uterus of vesicular mole, it is soft, big uterus. So give oxytocin, then make the uterus contract and retract, then do a gentle curettage so that you make the complete evacuation in the first instance itself. And in spite of that, at the end of 1 week, do a second ultrasound study. And if there is anything remaining, do a second curettage to make it complete. Once you have made it complete, any rise in the HCG is not due to incomplete evacuation. It is all due to the condition of GTN developing. So you are very sure then the rise in HCG is not incomplete evacuation. So that is what we have to do. So I don't think it is difficult to evacuate. it is very easy to evacuate. And I am a general obstetrician gynecologist who has done so many cases. So you don't give to the oncologists. They are not experienced in evacuating the uterus. I'm sorry to mention that. It has to
So,
be done.
sir, we also,
Sir, excuse me, sir. I have a question, sir.
I'm sorry, Jaya. Sorry,
no,
Jaya.
I would just like to
You are,
mention that.
you are basically a gynecologist and an oncologist, I hope.
No, I am a medical
Medical
oncologist.
oncologist. Medical oncologist. No, you are not used to these things. Sorry.
We have sir, we have gynae oncologist from.
Gynae oncologist will know.
No, sir. Professor Dr.
Okay,
A.K. Goodman.
okay, please. It
Yeah.
is. I said just on a very light mode that
Yes.
maybe that better it is
No,
done.
no, sir. We have another faculty. She is Professor Dr. A.K. Goodman from Boston.
Yeah.
I want to hear some comment from A.K. Goodman, sir. She is
Yes.
professor in gynae oncology in Harvard Medical School and the fellowship program director, Professor Dr. A.K. Goodman. Goodman, please.
Good man. Okay, I saw her. That's true. Yes, ma'am.
Hi. Hi.
Yes. Yes.
Hi.
I know that you are from Boston. I came to know.
It's a pleasure. It's a pleasure to learn from you, and I think that you have given a beautiful analysis, and I agree with everything you're saying. So my comments really are more, and you've touched upon this too, looking at the tragedy that we have in front of us, and to spend a moment respectfully to honor the passing of this young woman, one of many women who dies of a reproductive health problem, and then ask the question, why did she die, right? I mean, we've talked about the granular details of what happened with her disease. She had a disease that's common in South Asia, gestational trophoblastic neoplasia, and you have beautifully discussed the sort of standard of care that's available to treat her, and all the problems, the issue of potentially an invasive mole, the issue of what to do when you need to re-evacuate a uterus, the question of conservative management versus a hysterectomy, whether you do single agent versus combination chemotherapy based on their risk factors, all those things you've beautifully discussed. And we're really left with, ultimately, within a year from her initial presentation, this young teenager died. And so why did that happen? And so I just, again, we are all medical people, and we work as individuals dealing with one person in front of us at a time. That's how we've been trained. That's how the world is structured for us to care for people. Yet she died because of something bigger than each of us can individually do, which is she died because of an infrastructure in society, right, that didn't capture her for whatever reason. Maybe because she wasn't educated, maybe there was poverty, maybe she was unable to pay for therapy, maybe she was in a family where she wasn't making decisions, it was her husband who made decisions, and he did not understand the dire nature of her problem. You know, maybe it was a transportation issue. We don't really know those answers. I realize we're in a scientific oncology tumor board and we're talking about cancer, but I think that very much taking care of women as oncologists, we cannot ignore the social dimensions that are involved here. And I believe, this is my call to action, I believe that it is our duty to participate in that, to call it out, and also to educate, and perhaps to even work with governments and hospitals, social services, whatever it is, religious organizations, to somehow figure that piece out, because the mortality rates are just unacceptable. So that's my comment. Thank you for asking. Thank you.
Sure. So I think I just wanted to share an experience, because you mentioned this social problem, and sometimes it is, just beyond our comprehension. So once I scolded, a lady who was a young patient, and I scolded her for like 30 minutes, on this thing of compliance, and why can't you just even, go and take a bath? Because, she used to come with repeated infections. And that is when she told that, she was coming from one of the slum areas where there is no running water. So she used to walk for 5 kilometers to fetch that water. So after she said that, then we realized that it is so difficult because that is just beyond our, thinking of normal. So then our actually social workers came into place. They gave her, ration and food and other things. And then she used to come for follow-up. So I think, and they have played, I mean, we are fortunate enough to have, being in a tertiary center, that we had a lot of social workers and a whole lot of NGOs who were committed, and they have made a lot of difference. And I think, in each place, many of these patients who are survivors, they would be committed enough to take this up and help other people. And that is that's the way the most of these patients have actually come up. And so they call them up if they don't come for follow-up. Of course, out of 10, if we call them up, 8 would come for follow-up even if it is delayed. So we don't miss out on that window. So we keep, like nowadays most people have mobile numbers, so we keep their mobile numbers, we call them up. Of course, 2 out of 10 may not turn up even after repeated calling, but at least the other 8 who would have defaulted, they do come for follow-up. So that is a, just a small thing that I wanted to share, because they are so difficult, but it is also gratifying. And as sir rightly mentioned, that talking to the whole family together is so important, because it may be the husband and the mother-in-law, so you have to have a whole group family discussion with every member sitting there for them to decide. And also many a times, at least for us in cities, they are not able to stay there. So then liaising with people in the peripheral centers, where the patient might be, she might not stay in the city, but go back. But like something like a single agent methotrexate probably can be delivered at a peripheral center as well. So those are the kind of things which have helped us.
Naturally, we should have the referral centers, regional centers for India and Bangladesh. We should have regional follow-up centers. They cannot come to tertiary care like Mumbai from the periphery. There should be intermediary level of reference centers. Unlike the UK and even US, we don't have any such a dedicated center. That is one of the deficiency in India and Bangladesh. We are trying to have some regional centers. We started in one small teaching hospital. There is the only center that way working, which I should say now. But we are trying to get more centers. In Bangladesh also, there should be regional centers who are trying to coordinate these patients. As Madam was telling, everybody has got a mobile phone nowadays. Call them back at the appropriate. That is one solution. It's a very good solution. So, so that this tragedy could be avoided.
Yes, sir.
Good morning, please. I had been to Boston to see Berkowitz is our president today, nowadays, the next president. So hopefully he'll come again. Okay, ma'am. Thank you very much.
Shana, can I make a comment?
Yes, madam. Yes.
Sure. Okay.
Good morning and good afternoon to all.
Madam,
Good evening.
Madam,
Basically, I am in the same timeline with Goodman, because I'm in Toronto, near to Toronto now. So we are in the same
Madam, just
timeline.
I want to introduce you, madam.
Okay.
Professor Firdausi Begum, she is our president-elect in Obstetric and Gynecological Society of Bangladesh. She wants to talk something. She is in Toronto. We are very much happy, and we must very much thankful to our madam for participating in our program. Madam, please.
Thank you. And basically, I am also presently the president of South Asian Federation of Obstetrics and Gynecology. So I'm very happy, particularly because of this oncology club for the leadership and organizing discussion about different problems of gynecological cancers, gynecological and pregnancy-related cancers often. So I congratulate and request you to continue this with full zeal with this leadership. So that's one. Dr. Jaya has very particularly mentioned something, that during follow-up, we sometimes disgrace the people because a few days back, there is the abortion-related study which was done in Naripokko. There it was focused that when these abortion patients, say induced abortion patients, comes to the service providers, they behave very harshly. That why you're unintended pregnancy and all this. I think this is a duty of the doctors to ask why this unintended pregnancy has happened, but they should not be harsh. It should be dealt very carefully. Similarly, when a patient of hyaluriform, choriocarcinoma or this sort of gestational trophoblastic disease fails to follow up, we should alert them. Their follow-up is very much necessary, but they should not be subdued. Our language should not be harsh. That's very important, Jaya, because they work with so many limitations, and sometimes the information is not reach up to them, which is basically our failure. So this is very important. I missed the first cases because I joined a bit late. That's why I cannot focus on those. But I am focusing on the discussion I have had. And to the members of Oncological Club and Oncology Society of Bangladesh, I will request that the protocol we made on gestational treatment of gestational trophoblastic neoplasm, I think it's about 8 years back. So I think it needs to be updated. It was done on that time. It was not, Oncology Society was not there, so it has been done by OGSB. And I emphasize that I am seeing here that today, now it is only 82 participants. The discussion about gestational trophoblastic disease and gynecological cancer should reach all the members of the OGSB, all the practicing gynecologists. So how can we make that? So we can combine with other societies, maybe OGSB, or somehow we need to increase this number. So as the president-elect of OGSB, I extend my full support that how can we reach most of the gynecologists in the country so that it can be reached, and especially the referral centers. Basically, as far as I know, and as we do, that we start chemotherapy ourselves because there are no particular referral centers. So even though I'm not a oncologist, but in case of non-complicated or low-grade gestational disease, even when I see high HCG level, I start single-agent chemotherapy. And when it doesn't come down, I defer to, of course, the oncologist. So that is the protocol we follow here. But when we fail, or when we see complications, or when we are alerted, we want to reach people. Even us, the gynecologists, general gynecologists, want to reach specialists. So how can we reach? That has to be established. Dr. Shekharan was pointing out to that, and how the patient can be properly referred. Forget about us, about the peripheral level, say general GP, other sort of, they know that this is going to be a cancer. So with this specialist center, I think Professor Sabira Khatun wanted to start one in BSMMU and done partially. So this sort of referral centers has to be developed. So that is very important as well. We need to organize in that. So I think we'll be ending with this. One person should not talk much, but I think I may want to make just to hello to Dr. Goodman. I remember that about the publication and all this, and we recognize your contribution for the oncology in development of oncology in the country. And Dr. Shekharan, I think we met you in the bus on the way to from the Nalanda University, as far as you remember, in Patna. And but he is a freedom fighter for Bangladesh. Am I correct, Dr. Shekharan?
Yes, I crossed the Meghna River on country boats.
Yeah, so he had a great role. We must salute you. When the Pak Army has been sort of surrendering with the first forward batch of military, Dr. Shekharan, as a doctor, came to this country and helped us. So we salute you, recognize your contribution for this country. Thank you so much.
Shana.
Yes, madam. Madam, জি madam.
শানা, আমি অন্য একটা কথা ওই পেশেন্ট সম্বন্ধে তুমি বললো একটা জিনিস যে একটা রিজন I just want to request the Oncology Club and Dr. Shekharan and everyone to just to take the initiatives to start a regional center for the reference of the these complicated cases, our complicated cases. So I think if there is a strong initiatives and determinations of the concerned peoples, it will not really be impossible or very difficult to have it. It's a very good suggestion, and I will just request all of you to take these initiatives and make a center as a regional reference center where these women can get their better treatment. So this is an appeal to all of you.
I request.
So I take the opportunity to talk few words. So first of all, thanks to Madam Firdausi Begum and also Saiba Madam, the two very respected senior gynecologists of our country. And also Firdausi Begum is now the president-elect of OGSB. I want to say that we had worked with OGSB and we are always ready to work with OGSB or any organization, because our aim is to, Oncology Club, Professor Haisa, the president, is here. Our only target is manpower development and education. This is our main aim, and our founder, Professor IBM Karim, started like that. And we know that this is absolutely not only our domain. All of us need to work together. OGSB, Oncology Club, GOSB, whoever it may be. We all need to work together, fight together against this. It is not only science, there is commerce, there is arts, everything is combined there. And Madam, for the participation, just for information, this is a weekly program that we do. It is a fortune that we got. Faculties like Professor Shekran, Professor Annie Catherine Goodman, and Jaya Ghosh, it is their gesture that for a simple call from Oncology Club, they joined. And they made a simple program very valuable. So if we knew, 1 week back, that it will be such a big, rich gathering, maybe we would have invited much more people, because it is a routine, regular weekly session. So definitely we take your suggestion in future. Whenever we will see that we have resource person like Professor Shekran or Jaya or Catherine, definitely we will try to make the gathering much bigger. And working with you, Madam, whenever there is a call, Oncology Club is there. Thanks for the invitation, and we are always there. And bottom line, I think all of us wants to do one thing, that we want to do good to our patient. And unfortunately, all of our patients don't have all the ability. So we need to, we cannot wait them to come to us. Sometimes we need to go to them. Thank you very much, Madam.
Yes, Madam. Kamal Bhai, not only these 3 foreign faculties, there are also there Dr. A.K. Goodman. She invited other 4 her colleagues also. Some of them are joined here, and some also from the India. There are some junior, they're resident, and also some of our senior, the teachers, they have also joined with us. We are very much happy with all these participants. We have the resident and we have the junior doctors. They have different questions. They have several questions. You please let us to ask their questions. They have huge questions. Please ask your question. Yeah. Taslima, please. Or other doctors, have any question, you freely ask. Because today, yeah.
Madam, can I ask some question to Professor Shekran?
Yes, yes. Yes, ask your question, please.
Sir Shekharan, we are confused with WHO scoring system with 3 scoring points: antecedent pregnancy, interval from index pregnancy months, and pre-treatment HCG. There is a scenario like para 1, living 1, gravida 2, age 35 years lady, comes with PB bleeding after 7 days after DNC. So what will be her antecedent pregnancy? Number 1. And at that time, she has no, without any her beta-ICG report and no HPR report. So what will be her pre-treatment beta-ICG level? And how do you count the interval from index pregnancy?
See, the WHO scoring actually was from Baksho. Baksho was the person to start with the scoring system, then which was taken by WHO. Now it is all taken by FIGO. Now the final thing is only FIGO scoring system. There is some modification from the WHO, and this is the final one. Now what we are following is the FIGO scoring system. Now antecedent pregnancy means the previous pregnancy, whether it was a molar pregnancy following with the GTN has come, or following an abortion, or following the term pregnancy. The interval also from that index pregnancy means from what was the previous pregnancy event following with the patient developed GTN or choriocarcinoma. It may
Sir, from diagnosis,
yeah.
sir, from diagnosis or after evacuation, interval from where we count?
From the last pregnancy means not from the LMB, after the evacuation.
After the evacuation or termination?
Termination of the pregnancy.
Sir, at the time when patient come just after, just 7 days after the evacuation of a mole, at that time the index pregnancy, the interval from the index pregnancy less than 4 months, isn't it?
Yeah, sure.
Yes, thank you, sir.
So from that last pregnancy where it was terminated, whether it was abortion or following a mole or a pregnancy also, that is the index pregnancy or last pregnancy.
Okay, sir.
That is also important. If it is after so many months together, the risk score goes up. The term pregnancy following with the development of GTN, there is given a term score of 2, while if it is following a molar pregnancy, 0. So it is all important. The risk factors are calculated from very.
Sir, here we need a clarification. The patient comes with PV bleeding 7 days after a DNC. At the time, she has no HPR report. So what will be her antecedent pregnancy? Is it the patient is para 1, living 1, and gravida 2? At the time, what will be her antecedent pregnancy?
Last abortion, last abortion or last evacuation.
Okay, thank you, sir.
Last termination, that is the that is from where you have to calculate. I hope it is clear. FIGO scoring system is very clear.
Can I ask one question?
Yes, ma'am.
I have a question. In case of rescoring, sir, in case of rescoring after 1 year, and when we rescoring after 1 year, then from where we count the interval of month?
No, it is all from the diagnosis of GTN. When you have made a diagnosis of GTN, on what basis it is a GTN is diagnosed? What was the last pregnancy termination? That is the time we have to count. If it was following a term delivery, you may diagnose it much later, maybe even years. So that is the last delivery is the time you have to calculate. If it is an abortion evacuation, if you can get the date or somewhere, from there is the interval. So from the last pregnancy following which the patient has developed GTN. So in case of term deliveries, a choriocarcinoma develop and we may diagnose only after a year. So that is where it may be even a year before that. So that is where the importance of this interval from the last pregnancy is calculated. So 10 pregnancy may be diagnosing a GTN after some time only. Maybe the patient may come with hemoptysis or fits or signs of intracranial bleeding. So by that time only you will be in any woman of reproductive age with these hemoptysis and the signs of fits, you should check the urine for SCG or serum for SCG. Any patient is having any irregular bleeding following any event, or maybe you are taking a diagnosis of abnormal uterine bleeding, exclude pregnancy states by doing a pregnancy test. In all those cases, it could be a GTN or you are dealing with a situation like that. So it is important to pick up such cases. Otherwise, at that stage also we may miss. I hope it's clear.
And even patients with pyrexia of unknown origin, they need to be investigated.
Yeah, should be investigated and seen. Urine sample test, urine pregnancy. The pregnancy of unknown origin, if it is not subsiding with the permission that we give for ectopic, then you have to go in for further investigation. It could be a GTN. So like that. So don't miss it so that we don't miss.
I have a question, please.
Yes.
Should we do routinely BTCG or simply pregnancy test for every patient who are undergoing DNC for abortion?
Oh, I didn't get it. Please louder, please.
Should we do routinely beta HCG or simply pregnancy test for every patient who are undergoing DNC for abortion?
Okay, that's a good question, because we are now seeing that ultrasound is being used for early pregnancy evacuation. The classical finding on ultrasound of a molar pregnancy may be seen only after 9 weeks or 10 weeks. If you are evaluating a patient at 7-8 weeks, you will see a failing pregnancy, missed abortion, unembryonic pregnancy like that, and you may evacuate it. It could have been a molar pregnancy which would have developed after 10 weeks to the full-blown appearance, which will be missed. So in these cases, that's why in any case of an evacuation abortion, if you do a urine pregnancy test after 1 month, it should not have been there. It should not be there after 1 month of an abortion. If it is there, means you have to be careful. It could have been something. The other thing is that even if you evacuated the molar tissue at an early stage, like 8-10 weeks, the incidence of choriocarcinoma or persistent disease is not prevented. Unfortunately, that is the other thing. So you have to check the simple urine pregnancy test after every evacuation, even if you are not able to study the histopathology in every case. In fact, when you are not able to see any fetal parts in any abortion, that patient requires follow-up after at least 1 month with a simple urine pregnancy test. And in any abortion, the urine pregnancy test will become negative by 15 to 20 days. So I am giving another 10 days. After 1 month, it should not be there. If it is there, that is something which is missed early. So these are some of the precautions that we can take.
Sir, I have a question. Sir, largest tumor size including uterus, how can we calculate this? And another one is number of metastases. And how can I score here?
Okay. When you make a diagnosis of GTN by the HCG level, then you have to look for metastatic sites to score the disease. You have to have a chest X-ray, including ultrasound of the uterus with Doppler study. If you do the Doppler study, you will see increased vascularity, which is again supporting the diagnosis of GTN, not only by the level of HCG. And when you see a chest X-ray showing shadows, that case has to have an MRI brain. If it is negative, then you need not routinely go for an MRI brain. So having evaluated all the sites like abdomen, liver, brain, chest, you give the score.
Yes.
That is how the staging and scoring is done.
Now has multiple lesion, then what score it get? More than one lesion?
You have to count it, and the size of the nodule has to be seen, the number of size, everything is scored. The number of score is also given, that number of metastatic site, the number of nodules, the size of the thing in centimeters. So less than 3 you don't give, more than 3 to 5 you give 1 point, more than 5 centimeters you give 2 points. So everything is in a tabulated form. You may not remember, keep it on your table, if at all once you see, and refer it and then score it. Then the question of lutein cyst, we discussed it. Lutein cyst is not a secondary on the ovary. It is due to the high HCG level, it is going something like a hyperstimulation syndrome in IVF pregnancies, where you stimulate with lots of gonadotropins. The ovary undergoes the same change. The same thing is happening in molar pregnancy with a high level of HCG. The ovary becomes cystic, multicystic, thin-walled, and the size may be 6 to 10 centimeter or even beyond. It can be bilateral. This is not counted as a mass. It is not to be taken as for staging. So also, if the uterus is bulky, by itself is not the measurement. It is any nodule on the myometrium that is to be taken as a nodule and count it.
Sir, just a minute, sir. It may be myoma. How can they? Sometimes they cannot differentiate it. There is a nodule in the myometrium. It may be either a myoma or it may be a invasive mole.
Doppler study, madam. Doppler study will show.
Yeah. Another thing is that if there is 8 metastatic nodule or 5 metastatic nodule in lungs, then it is called the patient will get a score 2. Am I correct?
Yes.
Yes. And largest tumor size. It is also in uterine tumor size and also the tumor size in either in liver metastasis or in the lung metastatic nodule size. Yes, sir?
Yes.
Yeah,
It has to
everybody.
be.
Yes.
So it is useful to have this table in your table.
Yes, sir. Yes, sir.
Or make your assistant to learn it. So it is very difficult. It is 8 points. You have to see the scoring is given. Initially, the liver and brain metastasis was given a lower score of 2. Now in the latest one, it is given the maximum score of 4. Since 2000 FIGO staging system. And also number of metastases also given the 4. More than 8 means 4. So it goes up like failed chemotherapy is also given points there, risk points. So this is the basis for deciding whether it is single agent or multi-agent. Having started C to complete remission. If the patient was responding and then in between the level of SCG is not coming, change the drug. Another single agent can be tried, or you switch over to the multi-agent because the patient is not going to. What we have done is, in a case where the patient was responding and later on after 3-4 courses, she is not responding well. The HCG is not falling, at least 15% should be fall between the courses. If that is not happening in multifirous elderly patient, we have done some hysterectomy also. And the response was very good. Afterwards, 1 or 2 courses and patient is in remission. So these are the ways of treating the cases that we see in our practice. And the extremes of reproductive age is the most important risk factor for hydatidiform to come. In teenage as well as elderly people, the abnormal ova is the cause of the hydatidiform and hence abnormal ova are more frequent in the extremes of reproductive age. So these are the risky group. Other than the previous history also is risk. So be careful on such patients and then regular follow-up. That is the only key. And there should be people are not able to come in. There should be some referral center in between the country, 1 or 2 or 3 at different part of the country, and then smaller centers to help them with the SCG follow-up. And then if it is rising or falling, then only can be referred. So initial workup can be done in a teaching hospital. The teaching hospital can function as a referral center with the Department of Obstetrics and Gynecology, Gyne-oncology, medical oncology there, and radiation oncology. Everybody should be there as a team. So it's a teamwork. Form a unit of a referral center, start working with the existing facility. You can start. You don't have to have a separate fund for this. Only thing is, other than your regular OP, have a special OP for this and sit together, have a register, put it in the computer or in a register. This can be used for analysis and follow-up and research. So you can give to part of this thing can be given as a research to the PG students also. They will be also with you. So like that, you have a center can be developed with the existing facility. If the patient can have a free ultrasound done in the institution, that will very well appreciated. That will be very good. If the SCG cannot be done, you have to get, as Jaya Madam was telling, you should have some facility like a voluntary organization coming to help us to subsidize the SCG estimation. So these are the ways to save the patient. As we have seen, this is because of the lack of follow-up. We lost a young girl, as Madam was telling. So that's all. I hope it is clear. So scoring is very simple, clear. Accordingly only we start treatment. And then in high risk cases, you have to minimum 3 or even 4 courses after it has normalized.
Sir, one more question, please, sir. When a patient comes in our OPD just after evacuation without any HCG report, we followed her with beta HCG for giving methotrexate or chemotherapy. At that time, her first beta HCG report was 50,000, and during follow her last report was 2,000. So before initiating her chemotherapy, which one will be her pre-treatment HCG level?
Now, whatever available HCG is there, you have to repeat it when the patient has come to you, and repeat it the next week again and see the pattern. whether it is same level or coming down or going up. Now, plateauing means a fall of less than 10% from the previous week value. That is the plateauing. A rise in value is not double the value. Even 3 values of more than 10% compared to the previous value is a rise in HCG. Or 3 values over a period of 2 weeks. Then you start chemotherapy, depending upon the scoring and staging. So it becomes something like a mathematical calculation.
No, sir, my question is for the figure scoring system, which one will be the pre-treatment HCG at first after the evacuation level or the last rising or plateau level?
No, the HCG pre-evacuation can be lakhs and above. So our practice is at least 24 hours after evacuation. See, the half-life of the HCG is almost 36 hours. That's the basis. So the high level will settle down if you wait for 48 hours. Even if you can't wait for at least 24 hours, some of this high value will come down. From there, you go for the next week, and the like, so that you are very sure. And make sure that it is completely evacuated. That's the most important thing. After 1 week, recall, do a scan, do the HCG. The scan, if showing something there, repeat the curettage. Otherwise, no second curettage. So it is all clear, I hope.
Yes, sir. Yes.
Yeah, I just wanted to mention, like, maybe your confusion is whether we take that 1,20,000 or 2,000, which is at the time.
Yes, ma'am. Yes,
So,
ma'am.
yeah, so I think it is the 2,000 that we would usually take. That is at the time that you are starting the treatment, or that time that we've made the diagnosis of that GTN.
Yeah,
That
exactly.
okay?
For the scoring,
Yes, for the purpose of scoring.
Yes. Thank you, ma'am.
Can I ask one question, Dr. Shekharan and Dr. Zaya, and also our faculty? That when we give, say, as a clinician, we give single length chemotherapy. So sometimes the HCG level, say it become 10 or 15 and stays like that. Even with further chemotherapy, doesn't go down. So what is the minimum level where the it has to be 0 or below 0, or you can have a minimum level after chemotherapy for this sort of cases?
It's a very, very important practical question. The beta HCG level, the normalcy, it depends on each lab will have its own level. What is known the laboratory noise, which they calculate, is sometimes it may be 5. For the some lab, it can be even 10. So you have to ask the people, what is your normal level? From that, you have to take it as negative or normal. So some lab will have. The other problem is what you said was persistently the patient will have the same level of HCG, which is real HCG, not responding to further treatment. Now this is a quiescent type of the disease where the patient is not responding to the chemotherapy. The patient is going to have 10, 15, 20, 30 under HCG, but not responding to your number of courses. The cells are not dividing. It has gone for what is known as the quiescent state. The chemotherapy will act on the dividing cells only. So these are not dividing. This is not dead. It is producing some amount of chemotherapy. I mean HCG. You have to wait, keep on monitoring this patient. When it start rising, usually it will be HCG-H which is going to rise. Then give the chemotherapy, it will be effective. Probably months together or even years you have to wait. So this is what is known as the quiescent stage of the disease. It will not respond to whatever amount of chemotherapy you are giving. A very interesting situation is seen like that.
Yeah, we often, sometimes we see these cases. Thank you so much for clarifying.
I just wanted to also add that sometimes, as Dr. Shekharan mentioned, that these patients, they may try, they may even normal. So somebody who has this quiescent, they may not eventually need any further chemotherapy. So, you just monitor them initially a little more closely. We get to know that this patient is not rising. So, say for a month, you and then maybe read it every 2 weeks. And once we know that it is not rising, then follow them up with monthly. And as sir mentioned, sometimes it does to not rise, or they even rise after years.
It can very rarely. Once it has become negative with the treatment, and that's why we said, so for producing 1 unit of HCG, 10,000 cells are to be there. So when you say it is negative, still there are some live cells in the body, and that has to be eradicated by further courses. That is where it has now gone to even 3 courses once it has become negative to eradicate the disease. And once you have done that, it is very, 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 very rare to have a recurrence of the disease in low risk cases. High risk cases also, after the completion of the therapy, you have to give for 3 or more courses with the multi-agent. Even 4 courses are to be given afterwards, depending upon the stages. Then only you can eradicate what you call drugs for the road. For the road you give. So it is very important to eradicate the cells. Having known the physiology or pathology of the HCG secretion, some cells are still viable. That has to be eradicated. So once it has become negative, still you have to give to see that it is eradicated. Once you have done that, we have seen a recurrence of the disease. I tell you, we have treated more than 304 cases personally, and there was no recurrence after this way we have followed up. So it is very reassuring. You can get a very complete cure in these cases, 100% cure with the chemotherapy alone. So that is the beauty of the disease, so to say. But it is very dangerous because it spread like a sarcoma through the bloodstream. That way suddenly it will go to the brain and lungs and everywhere. So thank you very much.
Good evening, sir. Sir, I have a question. Can I please?
Oh, yes.
We faced a patient, 25 years, para 1. She is diagnosed as a case of choriocarcinoma. Firstly, she was low risk, and a single agent chemotherapy was treated by single agent chemotherapy, but non-responsive. Then multi-agent chemotherapy was given, IMACO, and lastly, IPIMA also has treated by this patient, but still her beta HCG level is raising. The patient has wish to conserve her uterus for second pregnancy. She has also a more than 5 centimeter mass in the uterus. So what will be our next management plan?
See, first of all, when the diagnosis was made, is it after a period of time, then you are having a case with a second here and there. So if it was following a molar pregnancy, should have picked up before?
No, following abortion.
Following an abortion. Naturally, we have the complete follow-up. There is no follow-up possible because it is an abortion. And that is where I said, just do 1 urine pregnancy test after 4 weeks. If it is there, that is a dangerous thing. So the early abortion without a proper, it is not possible to even by ultrasound to make a diagnosis. So we are going to miss.
Sir, histopathology also done in this patient.
Curettage.
After first GNC, after 3 weeks, she also developed PV bleeding, and in ultrasonogram, there was cystic scattered mass in the uterus, and second DNC was done. And this product, from this product, histopathology was done, and it was trophoblastic neoplasia. And after that, her beta HCG was done, and it was more than 15,000. And after 1 week, it was 90,000. It was the scenario, sir.
Okay, you have to properly stage it.
Stage 1, risk score 3 at first, sir.
Yeah. Should have responded to single agent.
No, sir. No, sir. Methotrexate. No, non-responding.
How often the course was given?
Sorry, sir.
When the course was repeated?
1 second, this is.
Pardon me?
3 cycle methotrexate.
No, how often it was given?
How often? কতক্ষণ কিভাবে দেওয়া হয়েছে এটা বলেন?
First, third, fifth, and seventh methotrexate, and second, fourth,
after
folinic acid.
Completion of the course, 1 course 8 days. What is the interval for the next course?
2 weeks, sir. 2 weeks interval. 3
Completion
course.
1 more week. So you have to start the next course after 1 more week. That means every 2 weeks she should be getting, every 15 days she should be getting the course the ECG has to be seen, and then three or four courses is not the criteria. If she is responding, continue till it is negative. If she is not responding and there is no response, change the drug to another single agent, and then if actinomycin D, and that may be. We are all fond of methotrexate because the toxicity is less, and there is a very definite antidote, at least folic acid. So it is very good drug. We have got more than 80% remission rate, even though the randomized trial and other things are otherwise. But they didn't. They have compared with the weekly methotrexate. We are talking about the alternate day methotrexate with the folic acid is very effective. We out of 340 cases, only 6 cases occur in macro. So it is all possible to give complete cure can be achieved. You have to give it every 2 weeks before starting the complete count and the LFT, RFT, because the drug is detoxified in the liver and excreted by the kidney. So at least that much we have to do. And then if she is not responding, change out to other single agent. If that is not there, because that delay should not happen. If she is not responding, no point in continuing with the same drug. You have to change the drug. She will respond better to actinomycin D in some of the cases. And some of this low risk case will be playing like that, and you have to go in for multi-agent. And it's not that resistance is not seen. You get response to multi-agent therapy and a cure in there. So I don't know what has happened in this case.
So we just want to say that, many, of course, these are very far and few in between, but occasionally when rarely or rather when we do get such patients, so as you rightly mentioned that, we give them Imaco and then the line after Imaco would be EMA-EP. But at this juncture, we would also want to restage the disease. If she's not responding, see where are the sites of disease. You do a CT scan and an MRI to see, whether the disease is anywhere else. And after
Madam, CT scan has done. Chest X-ray. In chest X-ray, it was a normal chest diagram. In CT scan, only in uterus there was 5.8 into 4.6 centimeter mass, a moderate amount of collection within the endometrial cavity. Otherwise, all are normal. Ovaries ascitic, no ascitic fluid, no lymphadenopathy.
Her beta ECG is now only 160 after getting 5 cycle EP-EMA, and for last 3 or 4 weeks, her beta ECG is like, at first it was after the end of the 5th cycle EP-EMA, it was around 120, and the second week it was 169, and there was no other disseminated disease or no other area, there was metastasis, only the confined disease with the uterus, and we advised her. She has one side, we advised her for hysterectomy, but she wants to continue her.
A residual tumor can be, surgery has got a place in these situations of resistance, probably, or if she is not having any fall in the ECG, wait for that rise to occur. That may be around 100, maybe what is known as the quiescent disease. Or if there is any masses in the lungs or brain, or it is worth going for even for surgery or localized radiation, or what is known as the gamma knife sort of thing, Professor Jaya, maybe for required for the brain metastasis. It may not respond fully to the chemotherapy, maybe intrathecal if it is brain. So localized lesions, resistant lesions have to be resected even from the lungs, and if she is willing, hysterectomy is a very, very good choice, because that will make the tissue to come down.
And also, do we have a CT scan of the chest or only a chest X-ray? Because
only chest X-ray. She also have no symptom. We advised CT chest. We also advised CT chest, but report not yet available.
So the thing is that if the CT chest and then the MRI brain is absolutely normal, and she's had like on EMA-EP this plateauing, as sir mentioned, like quiescent, because the radiological findings can persist even after normalization of beta HCG. So if we maybe 1 or 2 more cycles of EMA-EP, because we're not sure whether it has plateaued or not, and then see if the values are remaining the same, and we've already given 3 or 4 courses after this plateauing, then we can just, stop and wait for a week. or 2, because if it is actually the true beta HCG, it will start jumping up. You know, it will become 200, then 400, and 600. Whereas actually, if it is the quiescent beta HCG, then it will either remain the same and come down, or it will start increasing. So I think if there is no other site of disease and she's not bleeding, after maybe 1 or 2 courses of the same chemotherapy, you can stop and see which way the beta HCG is going. If it is true disease and it is increasing and she's absolutely unwilling, the other option is to give her EP. So we give the 5-day EP like we give for germ cell tumors. So that is the third salvage that we generally use for these patients.
Now patient has no complaints, no PV bleeding, no complaints. On pervaginal examination, cervix healthy, no bleeding present, no pelvic mass. On 20 October 2020, after 6 cycle EPIMA, her beta HCG was 119. And on 3rd November 2020, it was 296, slightly raised. This is the last situation of this patient.
So I would suggest that, of course, we do a CT scan and an MRI and repeat a beta HCG after a week. If it is still rising, then probably it is disease which is there. And if she's then again unwilling for a hysterectomy, because that is the only site of disease, then one can go for EP. So the EP regimen is the 5-day cisplatinum etoposide regimen, which we use like for germ cell tumors. So that is the EP regimen that we use for these patients. Other options, of course, are TPT, but the third routinely used is EP.
Thank you, ma'am. Thank you, sir.
You will land in trouble like this sometime, occasionally, but usually they will behave well, actually.
Thank you very much.
Okay, thank
yes,
you.
Yes, sir. Kamal bhai, we have another case that is in carcinoma cervix.
So I think today it is too late. So I think we should thank our faculties. And what I realized after listening to all the lectures, that this type of 1 hour session and 1.5 hour session is not enough to make the thing clear to our junior colleagues. So I will talk with our president, and hopefully we will organize a long session of almost 3 hours. So we will have faculties and lectures and multiple case discussion like this, so that will be helpful for our junior colleagues to make it clear. So it will be a larger gathering in a bigger session. So I think today we can drop the third case because already it is 25 minutes more than our scheduled time. So Shana, I think we can stop it here.
Just a minute. Yeah, we want to organize a 1 day, it is 3 hours, the GTD workshop. Yes, we have requested our president and probably we'll get permission from him. But today there is the chairperson here. Another, we have the Professor Saiba madam, she has a patient, she requested me to discuss in this forum. Kamal bhai. She has a patient, one of her relative, Professor
Kamal,
please go ahead.
This is a mother of a professor and also a mother-in-law of another professor.
Please, madam.
Shan.
Yes, madam. She is a 92 years diabetic, hypertensive, ischemic heart disease patient, and her ejection fraction is 40%. With cardiac pacemaker, started having pervaginal bleeding 3 weeks back. Ultrasound shows diffuse endometrial thickening, and DNC was done. Histopathology revealed endometrial adenocarcinoma. Plans to do PET CT and the waiting for her further management. She's 68 kg, menopause for 40 years, and 7 children. And what will be our treatment plan for these patients?
And she had for PET CT scan, and she had a COVID test as a prerequisite. And yesterday, the COVID test reports came positive.
No, she's a CA endometrium is what I understand.
Yes, CA endometrium. 92 years lady, diabetic, hypertensive, ischemic heart disease. 92 years lady.
With pacemaker.
See, of course, in the middle of COVID, then surgery may be difficult, especially with so many comorbidities. And if she is not having very significant amount of bleeding, then we can wait for about 2 to 3 weeks till she becomes negative and then do the surgery. I mean, I'm of course not a surgeon, but maybe Professor Shekharan sir can opine on that. And the other thing, of course, is that if she's unfit, then to consider for radiation. But I think, if it is just because of COVID, then we can wait for 2 to 3 weeks by which time they will become negative and then go for surgery.
Can we go for high dose progesterone, Joya, for these patients? For preventive, if she has within this time excessive PV bleeding?
You may, but actually, I usually my gynecological colleagues, they do the high dose progestogen, so that is a possibility. But I mean, they are the ones who manage these patients, so I wouldn't really know for them. But yes, that is something that we can consider if she has increasing bleeding.
At this moment, she doesn't have a slight bleeding only.
In this patient will be, the fact that she's diabetic, hypertensive, and ischemic heart disease. So with high dose progestogen, there is a high risk of ischemic heart disease, as well as angina with so much of progestogen, and she's a diabetic also. So I think, just plain tranexamic acid might be better for her rather than going in for high dose progestogens, because that will really increase her further risk as well. I mean, the surgical colleagues can opine, please.
So the first choice must be the surgery, but some of our oncologists suggest the radiotherapy for her. So what should be the preferred plan? We have planned for surgery.
Madam, if she's fit, if her anesthetic, she is fit, everything is okay. And I also request Dr. Kamal Bhai to give his comment. Otherwise, and on my comment that she may go for surgery if he is anesthetically fit and everything is okay. And we may wait after several weeks. And during this time, not PET CT, we may advise her MRI. And after that, we may do only simple hysterectomy for these patients.
We asked for the MRI, but due to her pacemaker, from radiology department, they told it will not be good for her to go for MRI. They suggest the PET CT scan. What is your opinion of that?
Even a simple CT scan would do for her.
Yeah.
So you need not have a PET CT. I mean, depending upon her creatinine, of course. So that is the other concern, maybe, because she's 92. So between surgery and radiotherapy, this thing would be depending upon her overall general condition and fitness for her. And if COVID is an issue, I think we can wait for 2 to 3 weeks, by which time usually most of them become negative, and then we can put them on for surgery or radiation, depending on her fitness.
And for Shekharan and others, for the hysterectomy, which route? The vaginal hysterectomy would be preferred, or?
I'm not so my surgical colleagues would better opine.
Shekharan is here, or Shana, what is? Yeah.
Madam,
yes.
Suggested to a simple hysterectomy or non-descent vaginal hysterectomy, or
that is my plan, to do the non-descent vaginal hysterectomy.
Stage 1, grade 1 case if there is comorbidity. It is evidence-based, madam. And on the other hand, other thing, we could do a ERPR, immunohistochemistry, so we can grade the case. Either it is grade 1 or grade 2, or prognosis is good or bad.
Madam, Kamal here.
Yes. Yes.
What I will recommend that nowadays P53 is the recommendation for to find out this early stage whether it is high risk or not. But under any circumstances, what Jaya was telling, that the preferred treatment should be surgery, madam. Only we do radiotherapy to the inoperable cases where it is exclusively impossible to do the surgery. In any condition, if there is any surgery possible, we always prefer surgery. And surgery followed by adjuvant treatment should be the gold standard. Here, we should do the surgery and then we wait, because there is no acute situation. Once the COVID is negative, with as per the recommendation of the surgery colleagues, what Jaya was telling, I will personally, as a radiation oncologist here, I will say that we prefer that the surgery should be done. And after surgery, we will have the full specimen, because what we are seeing now is this grade 1 and all these things. Once we have the full specimen, we may have something more details information, number 1. Number 2, we can do the P53. Nowadays, this is a recommendation to find out the high risk group there. And then we can decide about our adjuvant treatment, whether we need to give vaginal cup brachytherapy or not, whatever it is. And this will be depending on the final histopathology. So my take here will be that we should, even she is an old lady having 4 comorbidities, but I think today our recommendation will be to do the surgery first.
Well, thank you, Kamal. Thank you.
Now I request
Anything else, Shahana?
Yes, madam. Now I request Professor Dr. Rokeya Begum. She is professor, and on behalf of the head of the department, Rajshahi Medical College Hospital, I request Professor Dr. Rokeya Begum, madam, to comment to this program. Professor Dr. Rokeya Begum, madam. Madam, please.
Shahana Udhu nai.
Probably she is disconnected. Yeah. Okay. Thank you very much. Thank you. Yeah. Kamal bhai.
Yes.
Yes, please ask the question and congratulate the Lord. Yeah.
Dr. Shekharan, please do be connected to me. Shana, Amar, give my email address to him so that we can be connected. Make a common mail so that we're connected again. Yeah, thank you.
Okay.
We want to organize a large program for the including all the OGSB members, the GSB and other all colleagues, and the whole day the GTD workshop, madam. I have requested sir.
Do not make a very weak program. People cannot attend. Make it short and sharp. So that
at least minimum 3 to 4 hours.
We'll do this, but I think it should not be a day long, because we are not specialists on this. We want to have very short but very important practical solutions. And I should take this opportunity to take Dr. Kamal, to thank Dr. Kamal, because I have seen your leadership during the last oncology conference. Very well managed, very strictly managed. So I was sort of during OGSB conference, I was citing his example that there must be some policemen like Dr. Kamal should be there, so that no lengthening of the sessions. Thank you so much.
Thank you, madam. It is not me. I have a big policeman over me, that is Professor Hai. He don't allow us to start late and end late. And so thanks, madam, for the appreciation and for your cooperation, acceptance. Definitely, we will never do a webinar more than 3 hours. Our program will be for 3 hours. We will design it with discussion with OGSB and GUSB together, so that maybe we will have a large target audience. As you mentioned, not a long program, but an effective program. Less lecture, more interaction, more case discussion to bring up the real life scenarios, so that the faculties like Jaya, faculties like Professor Shekharan can answer to our colleagues. And then real life scenario will give them, I think it is more important to discuss real life scenarios than only lecturing, because lecturing is one way. When it is a real life scenario, our junior will be making presentation, different cases they will bring. As we discussed the last case, these are few cases, but this is something that makes somebody's life miserable. One case is enough to make one's life miserable. And as an oncologist, I tell you to all our colleagues that like the gynecologist, we are not very much, most of us not commonly handling this type of patient. So whenever we have a call from our gynecologist that we failed with single agent and this type of situation, then also we are not always very comfortable. I mean, all our colleagues are not very comfortable. So they are sometimes not doing the justice. So I think it will be done for both gynecologists and oncologists. So Shahana, I think it is late. We should not keep all our seniors and the invited waiting. So let us finish it.
Kamal, please convey my regards to Professor Hai.
Sir is here, madam.
Sir.
Hi, sir is here, madam.
Assalamu alaikum, sir.
Walaikum warahmatullah.
Sir, come on, sir. I'm so happy to see you, sir. More than a year, we went together in my mentorship. I remember those days, sir.
Assalamu alaikum, sir. Sir is my direct teacher. I learned so many things from him. Not only clinical side, many things. Thank you, sir.
I congratulated Rajshahi Medical College. They did this program and made this program helpful. Rajshahi Medical College Hospital, and madam, we are doing there every fortnightly for different medical college. Last time it was Chittagong Medical College. This time Rajshahi Medical College, and next week it is debate and the journal club section. And after that week, it is from another medical college, and we are trying to accumulate all the medical college, the doctors, the gynecologist colleague, everybody to discuss their cases and discuss everything. Now I request Professor Hi, sir, please end the session.
Thank you, Shana. Really happy, very much happy. Problem that is put forward by our young gynecologists others. To discuss so thoroughly discussed, particularly by Professor Sekharan and Jaya. Really grateful to them. They have taken lots of pain and they are staying good for around 2 hours now. Hopefully, my heart will thank to all of you. You participated all the senior gynecologists of Bangladesh and from abroad. Catherine, who stayed so long, she's always with us. This type of problems, we should discuss it. Let our juniors learn how to handle these problems properly. Many times we cannot just counsel the patient.
রাজনীতির পলিটিক্স তো অনেক নোংরা, আমি তো ওখানে কাজ করতে পারি না, আমি চলে আসছি না। ইটিস পিটিস জাতীয় সম্পর্ক তো আমার কারোর সাথে থাকবে না।
Can you hear me?
Yes.
Am I audible to all of you? Okay. Okay, it's on night. It's a late night, already 11 past. I don't want to keep you for a long time. And today's discussion was very good. My heart to thank all of you for the problems that have been put forward by our young doctors. And also discussed very nice. Thank you all very much. Goodbye and
Thank you, sir.
Thank you, sir.
Thank you, sir.
Joya, please, we want you next time.
Assalamu alaikum.
Sure. Yeah, sure. Thank you.
So Jaya, we'll be meeting you very soon on the next program. Thank you.
So Shekaran, thank you.
Thank you.
Bye.
Thank you.
Professor Shekaran, thank you very much.
Nice chance for me to talk to you.
Thank you very much.
And as I said, I was very much involved with my involvement and sentiments. I participated. Thank you very much for this opportunity. Hopefully, once the COVID is over, I'll visit you.
Yes.
We want to. I mean, there are so many pending things for all of you. We will have a big get together once the COVID is over.
Thank God, let us have a chance.
Thank you. Thank you very much. So good night, everybody.
Thank you, sir. Good night.
Good night. Good night.
Thank you.
Good night.
Thank you, Professor Jaya. Meet you somewhere. Right.
Yeah, sure. Thank you. I would love to meet you.
Thank you. Thank you. Right.